Hi there, welcome again. This is Dr. Gideon Balongo. I'm going to take you through the topic stroke, as they call it by the other name, cardiovascular accidents. So, contents, we're going to look at the definition, etiology, risk factors, history, examination, diagnosis, investigations, and management. So, stroke by definition is the rapid developing clinical signs of focal or global disturbance of cerebral functions with symptoms lasting 24 hours or longer or leading to death with no apparent cause other than vascular origin. In a simple definition, also stroke is a sudden loss of neurological functions lasting more than 24 hours due to a vascular cause. So, etiology of stroke, we have two types of stroke. Ischemic stroke. This is a type of stroke which happens when a bloody clot or atheroma or emboli or fatty deposit blocks a part of brain from getting oxygenated blood. The brain tissue distal to the blockage undergoes ischemic injury since there is a severe reduced blood flow, thus ischemic stroke. Also, we have another type of stroke which is hemorrhagic stroke. This is a type of stroke which happens when there is a rupture of arteries in the brain and it causes bleeding to the brain tissue. A rupture can be caused by hypertension, trauma, aneurysm, etc. Also, we have another form of some sort of, we call it stroke or transient ischemic attack. We call it transient ischemic attack. It's a sudden loss of neurological functions that lasts less than 24 hours and has a complete recovery. It's similar to ischemic stroke and it can be caused by blood clots. Just blocking blood from reaching the part of the brain. Transient ischemic attack is a medical emergency, and if not treated, it can increase the risk of major stroke in the future. Risk factors for development of stroke: advanced age, also history of transient ischemic attack, previous stroke, hypertension, cardiac diseases like valvular artery diseases, bacterial endocarditis, arterial fibrillation. These tend to create some sort of clots within the ventricle, the atrial ventricles, of which can dislodge from the heart to the brain. We have diabetes mellitus, we have hypocholesterolemia, we have high plasma fibrinogen, major fracture of long bones of the lower limb, especially fracture of the femur, smoking and alcoholism, also obesity. These are risk factors which can lead to development of stroke. The main aim of the history and examination, on history and examination of this patient with a stroke, the main aim of the history and examination is to establish diagnosis, also to locate the site of the lesion, to identify potential modifiable cause or risk factors. Stroke has sudden onset, accompanied with the maximum neurological deficit, does not always progress. Progressive neurological deficit over days associated with space-occupying lesions such as brain tumors, toxoplasmosis, brain abscess, tubercloma, etc. So on this, we check or ask about risk factors, like example, hypertension, diabetes mellitus, rheumatic artery diseases, smoking, and arterial fibrillation. Also, past medical history ask about history of stroke, transient ischemic attack, and trauma. So, in examination, general examination should focus on blood pressure, pulse, and gas glaucoma score. So, on cardiovascular system examination, also look at arterial fibrillation. This increases the risk of emboli formation in the heart. Also, look at valvular diseases. This can lead to cardioemboli stroke. So, check for murmurs on cardiovascular examination to look for the status of the valves. Also, central nervous system, assess muscle power and tone, assess aphasia, expressive and receptive aphasia to these patients with stroke. Also, we tend to look at the reflex too, to check for reflex, check for sensation, and power and tone of muscles. Differential diagnosis. So differential diagnosis, we have HIV positive. If the patient is HIV positive, think of toxoplasmosis, lymphoma, cytomegalovirus, and encephalitis. Also think of cerebral abscess, think of tuberculoma, think of echinococcus cyst, and cerebral malaria. So radiological investigations, brain CT scan and MRI scan. The main goal of doing radiological investigation is to confirm diagnosis, also to establish the underlying cause and to identify the size and the site of the lesion. So other investigation we can do random blood glucose, full blood picture, malaria rapid diagnostic test, or BS for MPS. We can do blood urea nitrogen, and we can do creatinine. We can do some electrolytes, serum cholesterol screening test in children, because in children sickle cell tend to cause stroke. HIV serology, ECG, and echo. Management of a confirmed stroke. So management, you have to do A, B, C, D, E. Then assess swallowing. If impaired, put a nasogastric tube for feeding. Establish IV line. Catheterization, if the Glasgow coma score is low or the patient is confused. Also, treat hypoglycemic or hyperglycemia if present. Then we do a supervised 2-hour returning to avoid pressure sores or belly sores. Also, encourage early mobilization of physiotherapy to prevent secondary complications, example, prostatic pneumonia, DVT, pressure sores, and the contractures. Early socialization also tend to prevent depression to these patients. Medical treatment, if the patient is having ischemic stroke, give aspirin 30 mg daily for 2 weeks, followed by 75 mg daily. If the patient is intolerant of aspirin, then give clopidogrel 75 mg per hour daily. Give warfarin if the patient is having arterial fibrillation. Never give anticoagulants if the patient is having hemorrhagic stroke. Elevated blood pressure following stroke. Elevation of blood pressure following stroke is normal physiological response, so don't treat aggressively, or this may worsen the neurological deficit. Persistent, if the blood pressure is persistent high, then treat. Hypoxia, hypoglycemia, sepsis, and pyrexia all lead to worse outcome. They should all be treated. So with hypoxia, we'll give oxygen, while with hypoglycemia, we'll give dextrose, D10, D25. With sepsis, we give antibiotics, and with pyrexia, we can give antipyretic. Treatment, also consider treatment only if the blood pressure is persistently elevated in acute stroke during 24 to 48 hours. So if the blood pressure is greater than 220 over 120 in infarction and greater than 185 out of 115 in the cerebral hemorrhage. So for treatment of hypertension, we always give atenolol 50 or 100 mg IV or orally. We give nifedipine 10 mg sublingual for acute reduction within 30 to 60 minutes, continue to 10-20 mg per hour twice a day. Also, we give ACE inhibitors, example captopril 6.25 mg per hour BD. We give idarazine 25 or 50 IM or per hour 3 times a day. So, prevention of further stroke. Second prevention, we control factors. So, stop smoking, regular physical exercises and physiotherapy, diet, salt, lipid and alcohol reduction, treat underlying disease, example hypertension, elevated cholesterol, DM, and all. Give statins, example simvastatin 10 to 40 mg per hour daily, or any statin if serum cholesterol is elevated. Long-term aspirin of 75 to 150 mg daily only for ischemic stroke, warfarin if the ischemic stroke is confirmed. So that's all about stroke for today. Thank you for listening.